Thank you, everyone, and welcome to this session. I'll briefly be talking on Cleft surgical instrumentation. Following this outline, while I'm trying to look at the past, the present, and the future of the instrumentation in craniofacial cleft surgery. Instrumentation is very important in any surgical procedure, and having required instrument to a surgeon is as important as the skill of the surgeon. When the surgeon have the proper instrument, the surgeon's work is easy. And when surgeon apply this instrument appropriately, then he gets a quality and desired result. Proper instrument management is also pivotal to the cleft room, theater safety for both patients and the surgeon and other people in the theater room. The instrument for cleft repair are different from those of other surgical procedure. And because of that, it's important that the cleft surgeon be conversant with identification and know the principle of use of this surgical instrument. Cleft surgery is a very unique surgery because of the following reason. It is an artwork with a great precision. What the cleft deformity does is to cause distortion of the normal anatomical structure, and the cleft surgeons will be able to neatly realign those structure and get a very good result. Most of our patients are children, they are babies. And these babies, they have very tender tissue and very small oral cavity. So you have a very limited, a small specimen you are working with. And as you are working with this small specimen, healing with minimal scarring is the utmost goal. This is a growth skeleton. You don't want to perform your surgery and arrest the growth. So healing with minimal scarring is a very important goal. Also, you don't want to keep these babies unnecessarily long under anesthesia. So you are aiming at shorter operating time. You are aiming at minimal bleeding. These are babies with small blood volume. So you don't want to bleed them and the anesthetists, they start transfusing. You want good overall outcome, very aesthetic outcome. And you are going to do this basic principle, guiding soft tissue dissection and handling must be strictly followed. And you are going to do this, you need adequate instrumentation. Looking back at instrumentation, the history of instrumentation, surgical instruments have been manufactured since the dawn of prehistory and has evolved for decades. The evidence for use of knife in medicine date back to the Mesolithic period because the knife was the first tool to be made by man. And one of the oldest surgical procedures was trephination. That's the art of drilling hole in the skull using the flint knife. The rationale behind this is that those surgeons, they believe that when you make an opening into the skull, the demons that cause headache, epilepsy, and other disease can just fly out and get relief for the patient. Early surgical instruments were made of different types of material, stone, bronze, and all that. And some are actually plated to avoid corrosion. The blade, for example, has evolved from the fingernail to lasers today. Hippocrates was the first to describe surgical knife, which he called Macarion. The surgeon later embraced the term scalpel for surgical knife because they felt that the knife connotes danger, assault, is a weapon of death, whereas scalpel implies security as well with healing. So they find it more comfortable to refer to their instrument as scalpel. The word scalpel is an English word derived from the Latin scapellus. And scapellus were first used by Romans. Romans, the history told us that they are very proficient in metal work. So they have a lot of instruments there. And the one for surgery, they call it scapellus. The development of modern scalpel with different blade, as we know it today, was largely the result of Mr. Ken Gillick's invention of surgical razor, of safety razor in 1904, and Dr. John Murray of Chicago perfected the special handle for both single and double-ended razor blade. Morgan Parker and Charles Rosenberg introduced the reedback blade in 1936. This picture is showing us the early Roman scapellus, and this is how it looked like. But following the discovery of the razor blade, Dr. Murphy designed this. He designed this handle, which you mount the blade and have both single-ended and double-ended. But in 1936, Bart Parker, they give the rib back blade holder, which is what we are using today. The word scissors is from the French ciseau, which has been used since 12th century. And true scissors belong to the pivot forceps group of instruments constructed in two separate, usually equal halves, which articulate precisely with each other by means of stable pivot joint. In the opinion of Gross, scissors are nothing but two knives united by a screw and furnished with each with a ring handle. So the just two half of blade, knife joined together, and you have a ring in the handle for the hand of the surgeon. Hedges and View look at the blade better, and they describe scissors edge, the cutting edge, as a chisel, and in which the makers alter the bevel according to the tissue which must be cut. The design and fabrication of modern scissors are based on these principles. So this slide is showing us the early scissors. You can see the surgical scissors. After use, you remove the screw for cleaning and for sharpening. Gillies make a very good invention. He make a scissors that combine both the scissors and the needle holder. And this other slide is showing us the major scissors, that the first one that was made in 1930. This slide is showing us the early surgical, the early cleft surgery. And then the deformity is referred to as the hair lip. Figure 1 is showing us that deformity, the hair lip, while figure 2 is showing us the surgery. The edges are trimmed, and to suture them together, to join them together to achieve healing. 3 hair lip pin were inserted. And you can see figure 8 suture was wound around the pin, possibly as a form of dressing. And in the fourth, in figure 4, it's showing us the expected healing. As a surgeon, looking at this slide, the objective of cleft repair then is very obvious, and it is just to close the gap. You can imagine the scarification that will follow removal of this pin. The objective of modern cleft surgery is more than just closing the gap. Now we are talking of aesthetics. All those deformed tissue, the flare ala, all those things, they are neatly reconstructed. We are talking of function, and function is telling us about the construction of the functional layers. Functional layers that are reconstructed. And beyond that, we are talking of quality of life. Quality of life means that a surgeon cannot just finish the surgery and tell the patient to go. We are talking of speech, talking of the occlusion, and this is the essence of multidisciplinary approach to cleft care, which is the gold standard today. What are the factors that determine choice of instrumentation? Well, the procedure you want to do, whether lip palate, they have different instrument. The age of the patient, whether this patient is an infant or is an adult patient, is still in an environment with some adult patient. Then the type of surgery. What I mean by this is that whether a primary surgery or a secondary surgery. Secondary surgery, we have a lot of calculation and might need more instrument. The basic minimum requirement for a cleft lip to contain all these a representative from this group, a measuring instrument, an infiltration, local anesthesia instrument for infiltration, a cutting instrument, dissecting instrument, hemostasis instrument for hemostasis, to achieve hemostasis, then retractors and suturing set. Why do we measure, or what's the big deal about measurement? The modern cleft surgery is not strictly on mathematical principles and measurement. So the era of just cutting without adequate planning is an obsolete practice. And why do we measure? We measure because we want to get symmetry. We are talking about aesthetics. The face must be symmetrical to be aesthetically acceptable. For equitable distribution of tissue, these tissue, they are distorted, as I mentioned earlier, and you need to distribute them adequately if you want good results. Planning of incision. There are some of these procedures that once you miss the first incision, the result will not be as expected. Of course, for geometrical flap design. And to do this, the Castroveggio caliper is very popular for doing this, and it's very good for that. It's a 20 millimeter measuring range caliper, and with a lock at the handle, which you can measure and actually lock the measurement to transfer to other. So it's a very good instrument. Some surgeons use flexible flexible ruler for measurement. Most of these measurements are not linear, and so that one will not get a very accurate measurement. And after the measurement, you need to mark the specific point. In some cases, the anatomy is very clear, and you can see this point specifically, but in some you have to get it by measurement. And one can use to do this is a surgical marker. Some surgeons prefer to use methylene blue with a sterile toothpick. That one will also do the measurement. Some surgeons prefer to use hypodermic needle. And the essence of doing this is that at the strategic point, they want some of the blue to infuse into the tissue, so that even when they lost the surface marking, as they are cutting, they can still see the discoloration of the tissue to guide their dissection. And having done this, in the principle of limited bleeding, it's customary to inject adrenaline 1 in 200,000 for hemostasis. And to do this, a dental syringe is very ideal for that. A dental syringe is used to give dental local anesthesia, and is very good for this. The long needle is 27 gauge. It's very atraumatic. I can easily negotiate around where you want to infiltrate. In absence of this, a hypodermic syringe, 23 gauge syringe, with blue needle, specifically blue needle, is less atraumatic and is actually advisable. When I want to, in case of adult cleft lip repair, this same instrument is used for block anesthesia, infraorbital block, superior alveolar block. This same instrument is utilized. And now the cutting instrument, after you have infused the adrenaline, the cutting instrument, the surgical blade, the scalpel, the scissors are the instruments are commonly used to make your incision. For cleft, orophageal cleft repair, we are talking about the size of our patients. So size 11 blade and size 15 blade is commonly used. The size 11 blade is very good for the paring of the cleft edges. It's also good for self-dissection of orbicularis oris muscle. If you can do it carefully, there's a landmark. There's a plane immediately under the skin, usually yellow space. You can go neatly under that, then you can easily trim. You can easily pare your muscle. Also, there's some excess tissue that you want to trim. 11 blade can do that. This blade they don't easily, so it's advisable that a surgeon will get more than 2 or 3 ready, so that can be changed. Incisivate blade is very good for C-flap design in case when you are using the Millard technique. Is very good. Also, you can use for orbicularis oris dissection, and also there are some very wide cleft that you need to make circular incision in order to achieve additional advancement. 15 blade is very good for that. And by principle, when you are using this blade, you actually cut away from the nose to avoid slipping and damaging. So you cut away, as you can see this surgeon here. And it's also advisable that you cut in layers, especially for the beginner. You pare the surface, the skin, the mucosa before you go to the muscle layer. The blade holder commonly used is the backpacker blade holder. For cleft lip, access is not a problem. You have medical field right in front of you. So a short blade as backpacker okay for as a blade holder. There are round holder also, which some surgeons said that is more hand friendly, and a pen grip allow for wide range of maneuver of movement. Sometimes you need to your marking, you want to straighten out the tissue to adequately do this. A skin hook is very good for this, and it's a very sharp instrument that neatly hold the tissue for you. Is very in a traumatic manner. And you have the single-ended and you have the double-ended. Double-ended is actually valuable to pull up the nostril, especially when you are making your mark, your marking. And also, they are very good to retract tissue and also stabilize soft tissue. The tissue forceps is another inevitable instrument in cleft surgery. They vary in length, and usually they are held in the non-dominant hand. They can be toothed or non-toothed. The length for cleft lip is better to get the one that is as short as possible, since access is not the problem. The primary purpose is to grasp, retract, or stabilize tissue. They may also be used to pack gauze and pass the sponges, ligatures during the surgery. A pen grip position provides the widest range of maneuverability. The choice of forceps will be dictated by the amount of fragility and the tissue being held. The axial tissue forceps is very valuable, and that's what this slide is showing. The working end is very very small, and it's actually designed to grab delicate tissue, as we have in our cleft patients. So they are very valuable for holding the tissue and for the surgery. By principle, the tooth is used to hold muscle and periosteum, while the non-tooth is for the skin and the mucosa. Other forceps can be used. Brown forceps, as we have seen here, Gillies, Mackindos, they are all valuable. Much dissection, extended dissection is not advised in cleft surgery because you don't want to cause a lot of scarification, but you can still do some sharp dissection when you are doing lip repair, especially when you want to do rhinotomy. Primary rhinotomy, the scissors is very valuable. And Kilner scissors has been very useful in doing this. You have the curved and you have the straight. So it's good for sharp dissection of muscles. And also for trimming excess tissue. There are some tissue that just want to trim off. You don't want to pull, you want to pull. A sharp scissors will just go there and chip it off for you. And it can also be used for separating of muscle following the tissue plane. There are times that in a wide cleft that you need to make circular incision to have further advancement of the cleft side. After making this and you didn't get enough advancement, a slight periosteal elevation can be done, and this can be done with Howard's periosteal elevator to just gently elevate the flap for further advancement. For cleft surgery, not much bleeding is expected, especially if you infiltrate the appropriate concentration of adrenaline. But of course, a part of what will be your tray is a hemostat. And number one, curved and straight mosquito artery is very valuable for this. And in case if your patient is an adult patient, we know that in adult patient, the vessels are well developed, especially the superior labial artery. So after you have made a decision, a hemostat will be very appropriate to clamp the vessel. So these two, the mosquito aerosol is very valuable in doing this. And after you have got the adequate mobilization of your flap, you have mobilized adequately, then it's time to switch on. Just I've mentioned that in cleft lip, the access is not the problem. So you get a short needle holder, 30 cm, 15 cm will be very good. And we have different ones depending on the surgeon preference. The Mayo and the Crywheel holder are shown in this slide. Instrumentation in paratherapy is more challenging, but very easy if the basic principles are adhered to. And the basic minimum set that should be in the clear palate set include the mouth gag, instrumentation for adrenal infiltration, as I've mentioned earlier on, you don't want much bleeding, cutting instrument, dissecting instrument, peroxide elevator, retractors, and of course, suturing set. Why is instrumentation in paratherapy challenging? Well, you are working in a well-gated hole. You have the soft tissue gate, you have the hard tissue gate made by the hardest and mineralized substance in the body. And this gated hole, the gate must be kept open throughout the duration of the surgery. You're also working in a cavity with limited space. You have limited space to work when you're working in a hole. And this limited space, again, you are sharing with the anesthetist. The active is there, which you need to watch. Interference from soft tissue, also, you have the cheek coming, the tongue is still there. So all this is interfering with that limited that you have. There's continuous saliva secretion because the mouth is open, although the anesthetic will be able to perform some wonders to reduce this. You are making a cut on a living tissue, though there's bleeding. So all this make instrumentation in paratherapy a challenge. How do you overcome this challenge? Patient positioning. Successful palatal surgery starts with adequate instrument and good positioning of the patient on the operating table. If you don't position a patient very well, you will struggle with the surgery throughout and you may not get the desired result. The patient is placed in shoulder-level position with a shoulder roll to hyperextend the head for improved visibility of the operation field. You also place a head ring. The head ring will be slightly above the diameter of the head, so that the head will just sink inward to stabilize the head. The top of patient head should be at the edge of the operating table. And when you have done this, you have to have a self-retaining locking gag. In fact, if you don't have a very good gag, it's not advisable for you to start paratherapy. You have to protect the anesthetic tube. And by principle, for instrumentation in paratherapy, is slender. We are talking of limited space. Lightweight. Lightweight, you want a heavy instrument that will strain the hand of the surgeon, because paratherapy is likely a longer procedure than cleft surgery. And a long instrument. So the instrument should be slender, lightweight, and long. By principle, a fork, a fine-tooth pickup, and scissors must be about 6 to 8 inches. That's about 5 to 20 centimeters long. That would be ideal for you. A needle holder not less than 6 inches is recommended. You must have a suction machine with a very fine tip. Then, of course, you have to infiltrate with adrenaline. And adequate illumination is very important. If you don't have good illumination, you may end up struggling also. So the headlamp is very good and stable. And in case where you don't have a reliable headlamp, a headlamp for the surgeon will be an adequate, will be a very good option. This diagram is showing the Boys David mouth gag. We said that we need a gag that will keep the mouth open as it will be self-locking, self-retaining. You are not struggling with the gag. So this is one of the common gag. Have 3 blades, and the blade is a little bit concave to allow for the anesthetic tube. And we have a fixed upper blade that goes into the palate. The clinadot mouth gag is similar. The only difference is that the palatal arm is just a hook. It's a hook that you move right and left. But in case of a Davis Boyle, is stable. Though this gag, they open the mouth very readily for you, but you can see that there's nothing that go for the cheek retractor. So the Dingman mouth gag is a better option if I may say, because this one has a tongue blade, and this tongue blade just a set, and this set you have the small, the big, and you have the medium, and you have the adjustable upper hook, and in addition you have a cheek retractor, and this one make it a very good option. This slide is showing the Digma retractor on a model, showing you the right place of positioning it. I saw this available instrument with Professor Donko in Kumasi a few years ago, and thank for Dr. Solomon Obriyeboa for sending me the picture. This instrument is born out of the partnership between Seattle Children's Hospital and KATH Kumasi. It's a rectangular frame that have a round knob, as you can see, at the edges, the round knob at the edges, which can be removed. You can actually remove it to resemble the instrument, and you have 4 meters in your hand. It's a simplified stainless steel gag, and incorporated most picture of the dot and Digman gag. Here, this is the palatal arm to go into the palate. The cheek retractor is also there. You have the cheek retractor, then you have the tongue blade also there. It's lightweight, and you know the advantage of this is it can move laterally and vertically, so you have a wider range of movement. Another good advantage about this, good thing about this material, this instrument, is that it has a hanger for small oral endoscope, and you can actually mount your endoscope there. And while you are doing your surgery, your training in the operating room can actually watch on their phone or iPad, on their personal instrument, their personal devices. And all what you need to do is just to put the software install the software on their device, and they can watch. You know that in cleft palate surgery, it's only the operator and the assistant that can see it very well. So this instrument is very good for teaching. And above all, this instrument is pocket friendly, and that costs less than $100. So this instrument may actually be a very good option for our sub-region. After you have activated your gag, there are things to check off. You don't just start cutting. You check off for something. Number one, you check off, look at the upper arm, whether they are resting. If they are resting on the teeth, you have to readjust. So it's not resting on the teeth, and it should not be resting on the cleft. It should allow it to be on the cleft. It will not be stable. Also, you want to look at the blade of the gag that is not impinging on the posterior pharyngeal wall. Maybe it's too long or it's too big. You might have to change it. You have to look at the tongue blade, not compressing too much on the anesthetic tube. Earlier in this series, the anesthetic they came here to so concerned about surgeons that came to their tube and cause endless list of problems with their tube. And I strongly believe that you won't want your name to be in their bad book. So you have to always check with your anesthetists whether they're comfortable with the pressure of the tube before you proceed. As you continue with the surgery also, you have to constantly pay attention to the tongue and make sure that it's not sinus, maybe it's compressing on the teeth, and you might need to relieve the gap if this one is done. Having done this, you infiltrate using the instrument as I mentioned above, and you can now continue your surgery. The blade holder, we as a principle, I've mentioned that long instrument, because you are working in a cavity, is actually advisable for paratherapy. So a backpacker number 7 is longer, it's slender, and will perfectly fit to this. Although if not available, backpacker number 3 can also be used. And for the blade, we still use the same blade for the cleft lip. And number 11 blade is very good for peeling the medial cleft edges. Some surgeons prefer to remove a tiny tab of tissue from the edge of the cleft, while some surgeons prefer to make an incision on there's a gray line separating the oral mucosa and the nasal mucosa. Just trace this line. Whatsoever you prefer, surgical blade number 11 is very good. And for the lateral incision, number 15 is actually valuable for doing this. Having made your incision, you want to raise the palatal flap. A cleft palate raspberry is very ideal for this. This is a pair instrument, come right and left. And if you hold the instrument, it is a flat instrument with a curved, the curved working end to fit to the anatomy of the palate for easy maneuvering of the palatal flap. If you hold the instrument with the concave facing up, facing you, and the instrument facing each other, the one on your right hand is for the left, while the one on the left is for the right. And when you are using it, the concave part is facing the bone, as demonstrated in this diagram. In absence of a raspberry, Howard's parietal elevator can be used. While using this, you have to be very careful to get a very good finger rest. You don't use the teeth as your fulcrum. You get a good finger rest. The instrument below is called a Kumai scaler. A Kumai scaler is primarily a dental instrument for scaling and polishing, but it's very useful, especially the spawn end is very useful to free the nasal mucosa, and also when you are doing the intravelar dissection, it's good for mobilizing the muscles. For dissection of muscles, Steven tenotomy scissors are proven to be very useful because of the design. It's slender, it's long, and it's actually designed when you are working in a small or narrow area, like you are working the cleft. It's also very sharp. So when you are dissecting your muscle, it can be a very good option. Other scissors that can be used, the merizemium scissors, the blade is not as sharp as you have in the tenotomy scissors, and you have a long size that can be as long as 18 centimeters, can also be valuable in your dissection. These are other scissors that can be used. The Kina scissors, the renal scissors, all of them, they can be valuable. And having mobilized your flap adequately, you want to start suturing. By principle, the needle holder of your choice should be long, 15 centimeters and above. And when you are suturing, you have to be very careful of especially at the uvula. Don't pick your throat pack. This is just to show you the pickup. The pickup should be at least 15 to 20 centimeters long, and you can see the gag appropriately positioned. Alveolar bone graft is repair of alveolar cleft, and this topic has been comprehensively dealt with last week. What we need, the instrumentation is just the soft tissue set. We have been told last week that you have to do extensive soft tissue work in order to get a good to get a successful bone graft. So all the soft tissue set mentioning earlier on, they are also, especially for cleft lip, they are actually also valuable for alveolar bone graft. Bone cutting instrument to take your bone graft, parietal elevator and retractor are also needed. So this blade is just slide just showing us some of the instrument you need to have in your set. For the bone harvest, especially if you are using anterior iliac crest, as we do in my center, a blade number 10 blade is actually better for iliac crest. And also you need a chisel, you need a mallet, and Bosman scoop to remove a cancellous bone. This is a parabol parietal elevator, which is valuable, especially when you are working in an adult patient. It's valuable to gently retract the gluteal muscles when you want to take your harvest from the anterior iliac crest. For children, it can also be used. What happens is that most of the children, what you have there is just cartilage. You can just use to flip the cartilage to the gluteal region, and you can now see the bone and take your graft. To take the graft, a chisel can be used depending on your preference. If you are using only cancellous bone, You will not need this. Just flip the cartilage and you can now scoop as much as you want. But if you are taking inner plate, you want a cortical plate with it, then a chisel is a good material to take your graft. And when you are doing it, you have to be very careful because these are tender tissue, small children, and so you don't apply an inadvertent force that can cause much damage. So you just tap gently with your surgical mallet to take with your mallet to take your graft. Bosman scoop is very good. You have different sizes. You have double-ended, you have single-ended, and it's just ideal to scoop cancellous bone when you want to take your graft. And having take your graft, you want to now inside the graft in the cleft, in the alveolar cleft, you need a good retraction to do this. And Langenberg retractor is a very ideal. You have different sizes depending on your patient. The good theater arrangement and positioning of personnel is important for smooth instrumentation, and it influences possibly the surgical time and safety of instrument. So this setup is showing us a theater setup for a right-handed surgeon, and you can see the surgeon at the head of the patient, the assistant at the left, and the scrub nurse at the right hand. And the instruments are selected based on the procedure of the day. And it's advisable that you don't crowd your tray unnecessarily. Any instrument that is not needed should be removed from the tray. And the scrub nurse arrange the instrument sequentially the way it's being used by surgeons. It's very good if you can have a scrub nurse that will be a member of the team. You know, some of our institution nurses, they rotate through units. And by the time a nurse is coming from O&G or from urology, he will not know about your instrument. So you can get a scrub nurse that will be a member of the team. That will be very ideal. He will arrange, she or he will arrange the instrument according to how the surgeon need them, and can preempt what the surgeon needs and give it to the surgeon. This makes the surgery very fast, and the surgeon will even enjoy the surgery. It's advisable that the cleft, the scrub nurse clean the instrument. As the surgeon is moving from the mouth of the patient, you take blood from it, and remove any tissue so that the cleaning will be easier. How do you now care for this instrument? You have good instrument. How do you care for them? You know, there's a basic rule to do. You handle your instrument with care. Avoid dropping instrument or scratching. I know some are showing you have to engrave a name there, but ideally you should not even scratch the instrument. You should follow basic standard protocol while cleaning. There's some instrument you need to clean. You need to soak before cleaning. You need to use a metal brush and all those. The protocol should be followed. The scrub nurse will have to recount the instrument after the cleft surgery. This one is very good so that you not miss your instrument unnecessarily. And you have to store this instrument with care. While you store dry, so all the instruments should be kept dry before you store them. Delicate instruments will be packed with protective tips and silicone storage box insert. And by principle, always make sure that heavy instruments are not stored on top of the lighter instrument. So if you have an instrument box, you place the heavier one down and now put the lighter weight equipment on top of them. A very important point to note, you must use them to do what they are designed for. An active forceps is not a needle holder. A needle holder is not a wire twister. When you use them for what they are designed for, they serve you longer and better. Also, it's advisable to avoid mixing different metals when packaging instruments. So those that are chrome plated should be kept separately, aluminum instruments should be kept separately, and stainless steel should be packaged separately. And also it's advisable that you audit your instrument at a regular interval. While auditing, there's a need to remove the bad one from it, and also if you need to procure new ones, then it becomes very evident. This can just summarize what I've said concerning instrument care. You clean, you disinfect, and in case there's some instruments that you don't use regularly, it's advised that when you want to store them, you lubricate them. You lubricate them for storage, and when you're about to use them, you pick them up, clean, and sterilize for the next surgery. Now looking at the future of instrumentation in cleft surgery, and it is the era of minimally invasive surgery. The robotic surgery may be a feature in cleft surgery. The application of robotic system in surgery is novel and has captivated many with the benefit it provides. Those are they say that there are a lot of benefit from this system. A slender arm, more motion scaling, you can actually gauge the motion of the instrument. Then tremor elimination, then it's very reliable, high fidelity. Then they said I tried three-dimensional visualization on the screen of your surgical field, make it an advantage. And this will make a robot a very attractive platform for use in confined spaces with minimal surgical target, like we are talking in the mouth. Transoral robotic surgery has been employed to perform a state-of-art oncological resection of the primary laryngeal tumor through a minimally invasive transoral approach. Podolsky et al. And few other authors has recorded a promising outcome in cleft palate repair with the Da Vinci robot system. So this one may be a feature. Another area the feature is looking at is the endoscopic surgery. It's also in line with the principle of minimally invasive surgery. The improvement of video endoscopic technology has boosted the development of operative technique for fetal endoscopic surgery. The main clinical application today is the treatment of fetal transfusion syndrome. Experimental intrauterine correction of cleft lip and palate has been lately performed using a fetal endoscopy approach, so it can actually transform from experiment to become a main thing. And because the advantage is that scarlet fetal wound healing, they won't heal perfectly without scarlet, and they say that it has actually decreased the maternal morbidity. For use in adult, Peng et al. Reported 2 successful nasal endoscopic assisted surgery for adult cleft palate. So this one may also be a very good future. In conclusion, primary instruments for cleft surgery have undergone different modifications over the past few years. However, the ideal ones are still being awaited. So there's still room for improvement. Use of appropriate and good quality instrument is inevitable in ensuring the expected standard of cleft surgery. Surgeon must be well versed with identification, indication for use, and technical use of different basic surgical instruments. The surgeon and the assistant must handle and store the instrument with utmost care. I want to join the earlier presenter to commend the Smile Train organization for great work of putting smile in the face of millions of children in our sub-region. In the spirit of sustaining this great work, our surgeon can collaborate with the Faculty of Engineering, especially biomedical engineering unit specifically, in our university for local design and fabrication of more affordable surgical instruments. The Seattle Kumasi retractor is a lead example of this. And a surgeon can actually look at how they can make they can design instruments and with engineers so that the cleft care can be more affordable. What are the take-home messages? Number one, you have to know your case. No cases are the same. Different cases may not be the same. So you have to know your case. You have to know your instrument, know what they are, know the indication of use, and know the application. You have to maintain your instrument. We are talking of area that with a challenge pocket to buy things. The little we have, you should be able to maintain it. You must be innovative. All the instruments you need may not be in your toolbox, so you may need to think outside the box to get things done. Then you have to work as a team. You have to get a scrub nurse that may about the instrument, giving you the instrument at the right time. And also the anesthetists, they are beside you. They are watching over your patient. They are also watching over you. You must respect their tube. I acknowledge the support of my trainers, Professor Gbenga Ogunlewe, Professor Akinladende, and Professor Hector Olasoji. I also thank the organizer of this program, the West African College of Surgeons, and the Smile Train organization for making me part of this laudable project. Thank you for listening. These are my references.
Thank you very much, Dr. Olutayo James. Ladies and gentlemen, I think we've had a very beautiful lecture from Dr. Olutayo James, and he has taken us through the series of instrumentations that are used, the sterilization procedures and all those, and particularly the historical aspect of some of the instruments. However, we have one or two questions here, a few of them actually, and I will pull 2, 3 together for Dr. Olutayo James to respond to. I'll start now. One says, can adrenaline solutions or the local anesthetic solution also be used for hydrodissection? There is another one is, there is this belief that the tooth tissue forceps are less traumatic than the non-tooth ones. What is your view on this?
Okay, so I'm going to answer that.
Yeah.
Yeah, the mixing of adrenaline, yes, it can be done. You can do that. Then concerning the tooth and non-tooth forceps, actually, if you look at the use, the non-tooth, we give a better grip. In fact, by principle, you're actually not supposed to grip through and through on the skin. You have to grip under the skin. So if you look at it, because the mouth there's precision in holding, so it's actually less traumatic in holding tissue. Where the tooth one is wider, and if you don't use it properly, you can still crush tissue with teeth. So if you look at it from that point of view, then you can say that the tooth one will be less traumatic than the non-tooth.
Thank you very much. Another series of questions from your experience, is there adequate cleft instruments in inventory? If not, what is your take on flash sterilization?
Flash sterilization is
okay.
When you steam instrument, when you just using steaming instrument unwrapped, and it's advisable that when you want to sterilize your instrument, you wrap them. It's very advisable because of what we have said. You want to keep them dry. You don't want to be moist. So it's advisable that when you want to sterilize your instrument, you actually dry them and wrap them before you sterilize them. I think that one will serve better and will make the instrument to last longer.
So the other part is from your experience, is there adequate cleft instrument inventory? Do we have adequate cleft inventory in this environment?
Well, it depends on what you mean by inventory. That's why I put the slide there that show you the basic minimum, what you have to have. Is want to do any form of cleft repair. And I mentioned there that it's better you put only what you need on your tray. You don't value your tray. So based on that, you can get the representative of what I've mentioned on the slide. They will actually serve you for the procedure. But the ideal inventory, there's none ideal one yet. But those instruments that I mentioned, if you have them, they will actually serve you to give a very good repair for your patient. Thank you.
Okay, thank you very much. Is there room for use of diatomy for dissection in cleft palate surgery?
Well, maybe I will say depend on the experience of the surgeon and the center. I mentioned earlier on that this surgery you don't want extensive dissection. You want gentle tissue handling. And shall actually follow all those basic principles. Inject adrenaline, you might not need to use a diatomy. This is a tissue that a growing skeleton that you don't want any damage of the tissue. So cautery may not be advised. We don't use it in my center. And anybody that will use it to be a very experienced surgeon that know exactly what to do, not to cause more trouble for the patient.
Sorry, just allow me to just pull about 3 questions together so that you take them once for want of time. Any need for throat pack in cleft palate surgery? Can we say the score is superior to the Dingman Dots retractor? In a situation where the standard mouth guards are not available, what or how would you advise us to use an improvised instrument? Or do you have any improvised instrument that can be used? I think you can take those 3 together.
Okay, thank you, sir. For the issue of throat pack, I think your anesthetists will discuss together if they have a good tube, a good cough tube that they are satisfied with. I don't think it's compulsory that you do that. But if they are not sure of that, it's advisable that you put a throat pack. We do it routinely in my center. We put a throat pack, and I think we have not really have any problem with it. If you are talking of retractor, if you note when I was speaking on the instrumentation of the cleft palate, personally, I will not advise anybody. You don't have those standard mouth gag. I will not advise you to embark on cleft palate surgery because you will struggle throughout, and you definitely not get a desirable result. So we are talking of a multidisciplinary care. We are talking of a specialist coming. If it's only lip you can do in your center, why not doing the lip and hand over to the next surgeon that have adequate instrumentation for the repair of the palate? I personally, I will not advise anybody to engage on cleft repair. I don't have the standard mouth gag.
The other questions here, can one improvise with the Warwin-James elevators since the cleft palate respiratory looks like it?
That's a very interesting question. It will not be adequate because Warwin-James has a very tiny working end. The respiratory look longer. The mouth look like Warwin-James, but it's longer. And the anatomy is curved to the anatomy of the blade such that it blends easily. When you go in between the perisome and the bone, it slides easily under the flap and you can move it up and down. So Warwin-James will not be an option. The working end of Warwin-James is too tiny to achieve what you want to achieve. If you do that, you might end up just tearing away the flap and complicating the surgery.
Okay. Is there any need for the use of NG tube postoperatively in cleft palate surgery? With the use of transoral robotic system, avoid or eliminate tremor from the surgeon's hand if he is still the one using the system? Or does he assign and instruct someone else to do it?
For NG tube,
yep.
Will I say depend on the center? We don't use it in our center, and I don't think any of my trainers have used it both home and abroad. I don't see it used before. But if some surgeons are using it and maybe it's working for them, I don't know. Maybe they will be able to defend it. But in my center, we don't use NG tube for after our cleft surgery. We don't use. And for the robotic surgery, what I read to you on the slide is from the literature. I don't have any experience. I've not seen it done. I've not seen the instrument. So I think the literature may be a better way to, if you Google, you might get the answer to the question.
Okay. Thank you very much. I'll just ask these last two or three questions. Please, the Cummins scaler and the Mitchell trimmer, are they the same? The other one is, how easy is it to get the mouth guard invented by Kumasi Hospital if one is interested in acquiring one?
Thank you, sir. Sorry, the first question.
Okay.
The first question, sir. Okay, the first, the Kuma and the Osomiche,
the
they are not
Kuman
the same.
scalar.
Both,
Yeah.
yes, sir. They are not the same. They are both universal scalar. The working end is different. You have one with cuff end. You have one with a eagle beak end. But they both of them can also do the same. And you know, there's another called a Freya we have in my center that also do that. So they are not the same, but they can, the Kuman, the Osomiche can also do the work, can also the spawn end can also help. Concerning the Kumasi retractor, I believe that Professor Donko is listening to us. He's going to use his big weight, throw his big weight behind the making the retractor available for our sub-region. Thank you.
Thank you very much, Dr. James. I will just ask, there's still a question here which I will just throw at you, though it's not pertaining to what you have just done now, but it's just for the information of the person that asked it. Kapetaski and Kaplan do not follow the rule of tens, and they did surgeries relatively earlier. What is your timing of surgery of cleft lip and palate? I know it's not part of it, but just for the information and to get across to the person that asked it.
In my center, we have we are smart chain partners, and so we have a laid down protocol for all our surgical procedure, and that's what we follow in my center. So we follow the smart chain laid down procedure protocol for all our cleft surgeries.
Okay, thank you very much for these wonderful presentations. I am sure all of us would have gotten one or two things from this lecture. It's been a privilege to be the moderator of this session. My name still remains Ajike Sunday Olusegun. I hope to see you during the next session. Wishing you all Barika do Salah. Thank you very much. Dr. Esther, take over.
Thank you very much, Professor Ajike. Thank you, Dr. James, for the wonderful presentation. We never realized how much cleft instrumentation has developed over time. There's a question to Professor Donko on accessing the mouth gag from Kumasi. I think we will get a response to that before we share out the presentation. Thank you, everyone, and see you tomorrow, same time, same place.